Hello and welcome to the Radiology Scholars Certificate Program. My name is Nick Till. I'm an MS4 at the Wake Forest School of Medicine. In this video, we'll be covering demyelinating disorders of the CNS. As an overview, here are the four entities that we'll be covering in this video. We'll be covering multiple sclerosis, or MS, neuromyelitis optica, anti-MOG encephalomyelitis, and acute disseminated encephalomyelitis. So starting with MS, the etiology is unclear but is believed to involve genetic predisposition involving the HLA subtype DRB1, as well as environmental triggers, including EBV infection and low levels of vitamin D. The pathophysiology involves autoreactive T cells that migrate to the CNS, react with autoantigens, and cause focal demyelination, which leads to axon and oligodendrocyte degeneration, and subsequent scarring or gliosis that impairs the remyelination process, leading to neurologic symptoms. Clinical findings are variable and depend on the area of the nervous system that's involved, but typically involve fatigue, unilateral optic neuritis, a relative afferent pupillary defect, or RAPD, INO, or internuclear ophthalmoplegia, upper motor neuron signs reflective of myelitis or spinal cord involvement, cerebellar signs, including scanning speech or imbalance, cranial nerve palsies, and autonomic dysfunction. Imaging findings, starting with MRI, typically see hypointensities on T1 sequence. Lesions will be hyperintense on T2 flare sequence, and these will typically be located in the periventricular white matter, which is termed Dawson fingers. Active lesions tend to enhance with contrast, and another feature of lesions in MS are that they are disseminated in time and space, and this relates to the McDonald criteria, which are typically used as a diagnostic tool for diagnosing MS. Here we have two representative images of the classic findings seen in MS. On the left-hand side, on this axial T2 flare sequence, we see periventricular white matter lesions that are hyperintense. These would be termed Dawson fingers. On the right-hand side, we see on the sagittal stir sequence hyperintense lesions in the cervical spinal cord that are short segment lesions and located eccentrically rather than centrally. And these represent some of the classic imaging findings seen in MS. The next entity we'll cover is neuromyelitis optica, or NMO. This condition is caused by autoantibodies that are directed against the aquaporin 4 protein. The pathophysiology, the autoantibodies react with this protein, which is located on astrocyte foot processes, particularly located in the circumventricular organs. And this causes immune-mediated damage to these astrocyte foot processes, leading to inflammatory damage. Clinical findings tend to see visual deficits, often bilateral optic neuritis, which is in contrast to MS, in which the optic neuritis is most commonly unilateral. Also tend to see paraplegia, which is reflective of longitudinally extensive myelitis. Imaging findings, so on MRI, these lesions will be T1 hypointense, similar to those seen in MS. However, they will be T2 flare hyperintense, typically located in the circumventricular organs, and tend to see longitudinal spinal involvement. Longitudinal referring to the fact that these lesions tend to span greater than 3 contiguous spinal cord segments. Active lesions, similar to MS, tend to enhance with contrast. Here we have a few images showing some representative findings, classic for NMO. On the left and middle images, we have T2 flare sequences of the brain showing hyperintense lesions located around the circumventricular organs, as well as some involvement of the ependymal margins. On the right-hand image, we see a sagittal stir sequence showing longitudinally extensive transverse myelitis, commonly affecting the cervical spine. And the longitudinally extensive aspect helps differentiate it from MS, in which we have longitudinal involvement spanning greater than 3 spinal cord segments. The next condition we'll cover is anti-MOG Encephalomyelitis. The etiology of this condition is autoantibodies that are directed against myelin oligodendrocyte glycoprotein, or MOG. Pathophysiology involves the autoantibodies reacting with the MOG protein, which is present on oligodendrocytes, resulting in immune-mediated damage and neurologic symptoms. Clinical findings can be variable, but tend to involve a viral prodrome. This is one of the things that's more characteristic about this condition than the others that we cover in this video. Have a viral prodrome, and then typically around 2 weeks later, a patient will develop visual deficits reflective of underlying optic neuritis, and paraplegia, reflective of longitudinally extensive myelitis, as well as altered mental status. Imaging findings on MRI, we have, similar to prior, T1 hypointense lesions. However, these lesions are hyperintense on T2 flare sequence. They can occur in the brainstem, cerebellar peduncles, and the thalami. In terms of spinal involvement, tends to more so affect the thoracic spinal cord as opposed to NMO, which has a greater predilection for the cervical spinal cord. And similar to the other processes, active lesions tend to enhance with contrast. Here we have a few images showing some of the classic findings for anti-MOG encephalomyelitis. On these T2 flare sequences, we see hyperintense lesions located in the brainstem, which is more common for this condition compared to others covered in this video. And then on the right side, we see a sagittal SIR sequence showing the longitudinally extensive transverse myelitis that has a predilection for the thoracic spinal cord. And so one way to differentiate MOG from the other conditions that we've covered so far is the thoracic spinal cord involvement and the longitudinal involvement. The thoracic spinal cord involvement can also be seen in MS. However, in MS, you tend to have short segment involvement, less than 3 segments, whereas MOG is greater than 3. And then with NMO, that tends to have a greater predilection for the cervical spinal cord. And so that can help differentiate this condition from the others that we've covered so far. Here's an example of optic neuritis, the imaging findings for optic neuritis, which is a manifestation of all 3 of the conditions that we've covered so far. It's a coronal T2 flare sequence showing hyperintensity around the left optic nerve, as indicated by the arrow. So to review what we've covered so far, this is a pretty useful Venn diagram showing some of the pertinent similarities and differences to help distinguish between these 3 conditions. Starting with MS, we covered the Dawson's fingers, or the periventricular white matter lesions, as well as the short cord lesions involving less than 3 segments of the spinal cord, as well as the unilateral optic neuritis. All 3 of these features can help distinguish MS from the other conditions covered in this video. Some distinguishing features of MOG are the brainstem involvement, cord lesions, which can involve the conus medullaris, or the most distal aspect of the spinal cord, the presence of bilateral optic neuritis, and the viral prodrome. All these can help distinguish this from the other conditions. NMO tend to see peripendumal lesions, bilateral posterior optic neuritis as opposed to the anterior optic neuritis, which can be seen in MOG. And in NMO, the optic neuritis can involve the optic chiasm, which is unique. Both MOG and NMO tend to have longitudinally extensive transverse myelitis involving greater than 3 segments. And all 3 conditions tend to manifest with optic neuritis and lesions within the brain and spinal cord. The final entity that we'll cover in this video is acute disseminated encephalomyelitis, or ADEM. The etiology is typically due to a viral infection or vaccination that triggers a monophasic autoinflammatory demyelinating process. The important aspect of this is that it is monophasic, unlike conditions like MS, in which there is relapsing remitting course. Pathophysiology involves autoreactive lymphocytes and antibodies, including those directed at MOG, that react with CNS autoantigens and causes inflammation, particularly located perivenularly. Clinical findings tend to involve a viral prodrome, followed by 1 to 2 weeks later, a headache, altered mental status, seizures, multifocal neurologic deficits, and psychosis. Classic imaging findings on MRI, you'll see multiple T2 hyperintense lesions that tend to involve the subcortical regions. And one classic sign for ADEM is called the open ring sign, in which you have a ring or arc enhancing lesion that's well seen on a T1 contrasted sequence. Here we have some images showing some of the characteristic findings for ADEM. Starting at the top, this is a T2 flare sequence showing multifocal hyperintense lesions located throughout the cortex and subcortical regions. And then on the bottom, we have a T1 contrasted study showing incomplete peripheral enhancement, one of the characteristic findings for this condition. With that, we wrap up our video on demyelinating disorders of the central nervous system.